Advanced Sports Med. Hope you guys are doing well. Let's go ahead and finish up this lower body pathology. We're going to start with kind of ligament injuries, kind of soft tissue injuries, talking about tendons and ligaments. Did fractures before, but now we'll move on to more soft tissue. All right. First one that everybody probably really thinks about when we talk about ligamentous injuries is the ACL, the anterior cruciate ligament. So the MOI for this is typically a plant and cut. So somebody goes to plant and cut to change directions, and for whatever reason, muscular imbalance, uneven surface, that ACL gives way. So with this, we also want to talk about contact versus non-contact. What do you guys think? More often non-contact or contact? It's actually more non-contact is more common. Due to, so a couple things that would need to be better for it to work. So your ACL, right, it helps protect your knee. But if you're doing something forceful, then it doesn't matter if your muscles around aren't strong and it's not supported. So, for example, some muscles that need to be strengthened would be your glutes. Maybe if this works. Glutes and hamstrings. And also form. This is both landing and jumping. And those are really the main parts as far as contact versus non-contact. If your glutes and hamstrings are strong enough, then your form's not going to be right, and then that causes some issues. Something else, males versus females, I'd say it's fairly common in both, but something with females. How am I going to go around this? Okay, something more that makes more common with females is their due to their Q angle. Oh. So their Q angle is the angle from the Q angle is the angle from the acetabulo-femoral joint to the tibial-femoral joint. So it's the angle from the hip joint to the knee joint. And when that angle is too wide, potentially, like sometimes with women, their hips are a little bit bigger or wider, right, due to childbirth. So that causes a bigger Q angle, which makes your knees go medial. Too wide makes knees go medial. That can cause to be predisposed to ACL injuries. So signs and symptoms. All right. So if somebody tears their ACL, very often, right, there's going to be a fusion fairly soon. Maybe not immediately, but I'd say after, within 15 minutes of the injury, you're going to start to have some effusion. Later into the night, it's going to be, very swollen pain, some minimal ecchymosis. There'll be some instability. It won't be stable. And then, so this is positive anterior drawer, positive Lockman. So these are these two are the special tests that we'll go over. And then also something that's not on here is they almost always feel a pop. When this happens, you almost always feel a pop. So treatment would be mobilization, getting the MRI, and then we're getting surgery, right? Rehab, and then usually you're back 6 to 9 months, and now they're usually leaning, especially with the high school population, we're leaning more towards 9 months. And the different things that people can use to replace their ACL with is hamstring tendon, specifically the semitendinosus, and actually your gracilis too, which is a hip adductor. You have the option for your patellar tendon, quadricep tendon, or a cadaver, which you shouldn't do, right, if you're a young person returning to play. So it's a very, very detailed, in-depth, involved situation. Next one we're talking about is the MCL. So the MCL would be, the MOI would be a direct blow on the lateral aspect, lateral knee. Or this can be associated with the ACL tear. Signs and symptoms. So you're going to be tender tube palpation at the medial knee joint. There'll be some effusion, and then this right there is the special test, the valgus special test. So those are kind of the signs and symptoms. Definitely that effusion, and then that valgus stress test, you could definitely feel it. It opens up. Treatment would be to immobilize. Typically, there's no surgery. Rarely do you do surgery on the MCL because the MCL doesn't, when it tears, it doesn't recoil. It doesn't move away from each other. So as long as you immobilize it, it'll come back. It'll scar tissue will come on there and it'll come back up. So if you have like a grade 1 MCL, you're looking at, maybe 1 week out. If you're looking at something further than that, for a complete tear, you're looking at probably, at least 3 months out. Meniscal injuries. Okay, so meniscus injuries, MOI is a shearing force, almost like a compression and then like a twisting motion. I think we talked about this already, but a lot of people think that the medial is the most common, but actually the lateral meniscus is most common because it's a pivoting point. Pivot point for the knee. So something to talk about meniscal injuries. A lot of people have meniscus tears. A lot of people, just general population, walk around with meniscus tears, and sometimes they're symptomatic, sometimes they're asymptomatic. It just varies. And when we get into treatment, we'll talk about that a little bit more. So signs and symptoms, you're definitely going to have effusion. So there's a couple symptoms that are specific to the meniscus. So you got joint line pain. Sometimes there could be like a catching sensation, clicking sensation, and you also might have decreased knee extension. Sometimes when it tears, it kind of flips, and then it limits your range of motion. McMurray's is the special test, and we'll go over that. Treatment would be NWB, which is non-weight bearing, because when you're standing up, you're putting pressure on that meniscus or irritating that meniscus. So treatment, this whole thing is changing. All right. So before they used to, somebody tore their meniscus, they'd, do an arthroscopic procedure. You're like, okay, I guess, first of all, I should say that the meniscus is avascular, or most of it anyway, so doesn't heal the best. So what people would do, they used to do a meniscectomy, right? So cut out the meniscus, like the bad parts of it, right? And then they just let it be so that way it doesn't get irritated. But what they found is that causes that this actually removing it is bad. Don't do this. If you go to a doc with a meniscus injury, don't let them remove any of it. You shouldn't do that. They found that just leads to more injuries. It leads to a condylar defect, which is an issue with the knee joint, where it causes like swelling underneath your cartilage of your knee, and it just turns into chronic pain, early onset arthritis. It's just bad. And even so, the meniscus too, it's like protection, right? It's protection between your femur and your tibia. If you take that out, that protection, that shock absorption is gone. So all you're going to do is just, in when you're 35 years old, you're going to start having knee pain. You're going to have early onset of arthritis, and it's just a downhill spiral from there. So we don't do that. So repair is the way to go. Repair is the way to go. And that way they stitch it up, they clean it up, and then you're not weight bearing for a period of time, but at least it'll heal, and at least you still have your meniscus. All right, moving on to ankles. All right, so lateral ankle sprains. So we got the most common, right? I think we talked about this. The most common sprained ligament in the body is your the ATF, the anterior talofibular ligament. Forced inversion or dorsiflexion. So signs and symptoms, right? So this is based on grade. So like a grade 2, this is where you're going to start to see the ecchymosis, edema, right? That's where we're going to start to see more of these symptoms, and then onward. But like grade 1, irritation of fibers, this might be a little swollen, but not bad. Something you can play with. So the thing with ankles, right? Either you could try to play through it, but if you play through it, you always got the chance of having it get worse. My determining factor is how strong is it? What's your range of motion? How much swelling is there? How much bruising is there? If there's a lot of bruising and swelling, it's like, man, why are you even trying to play, right? We were saying that. If there's that, you got a partial tear. That means stability is really loose. It means it could turn into a full tear. So you wouldn't want to do that. Might as well give it time to let it heal. Treatment, typically, so you got the RICE, NSAIDs. Something that's new for NSAIDs would be... I know a lot of people are going to the alternative medicine, like turmeric's a good anti-inflammatory. But NSAIDs are good if you take them as prescribed for a period of time, but you don't want to take them every day or, pop 6 Advil before a game every time, because that's just going to irritate your kidneys. And again, I mean, you got to live with your body the rest of your life. You don't want to be messing it up when you're young. And then there's a progression of rehab. So here's a quick progression of rehab. So we're going to go over this in detail as we move on to different units. So these first 3, you could really do together. Okay, so these are like the first steps on what you want to do. Whenever you're returning, this applies to any injury. So whenever you're dealing with an injury, the first 3 things you want to do, you want to decrease pain, you want to decrease edema, you want to increase range of motion, right? So those 3 things you could kind of do all together. Next, you need to take it step by step. So we want to increase strength, and we want to progress that first with, first we want to go, we talked about the different types of contractions. So, iso contractions to concentric to eccentric. But another thing with this too is you want to start with non-weight bearing and then move to weight bearing. And then you want to increase balance, proprioception, and you could do that different ways. Then dynamic ability, right? Some more like agility type stuff, and then sport specific activity. And there's even a progression for that. Next, high ankle sprain, also known as a syndesmotic ankle sprain. So that's just like when you hear a high ankle, you think it's maybe like higher up, but it's just right above your regular ankle. It's not too far. These are the 2 main ligaments, the posterior inferior tibiofibular and the anterior inferior tibiofibular. So it's the ligaments that hold your tibia and fibula together. So signs and symptoms are, where's MOI? MOI is forced dorsiflexion. That causes your tarsal bones to kind of push up into your tibia and fibula, and that's what causes it to to stretch. So we're gonna have edema, ecchymosis. You'll be tender to palpation. You'll be able to differentiate it from that lateral ankle, and then you have really decreased range of motion and weight bearing. So time frame. So high ankle sprains are rough because they take longer than a regular ankle, and it feels. So if we're doing normal rehab, it feels good and better, but once you progress into running, you just can't do it. It won't let you, right? So you feel like you're good, you start to try to return back to play, but you're back at phase one. Like we're talking probably like, high ankle sprain would be like 4 to 6 weeks probably. There's a tightrope surgery it's called, where like, I don't know, I think Tua, before he dislocated his hip or whatever, he had a high ankle sprain in college, and they did a surgery where it basically holds together your tibia and fibula. And it's actually a really good surgery, really successful. But again, you don't want to do surgery if you don't have to, right? And this could heal fine without surgery. So strains, most common strains are hamstrings and quadriceps. Forced movement or explosive movement, probably not warmed up enough. Signs and symptoms, the biggest thing is when you test for strength and stretching, that's when you're going to know if it's strained or not. Treatment, it follows kind of the same treatment, cryotherapy, thermotherapy, E-stem, NSAIDs, all that stuff. Tendinitis, chronic tendon issue, most commonly on the patella or Achilles. Signs and symptoms, it hurts before and it hurts after, but it's better during activity. We need eccentric motions, we need heat before, ice after, and then medial tibial stress syndrome. So this is shin splints. So, there's all kinds of things that mess with shin splints, right? Tons of things. It could be increase in activity, decrease in activity, old shoes, new shoes. That's why you have to go through this process of elimination. But basically, it's the periosteum pulling off a piece of bone. So that could be extra credit maybe. So periosteum is that tissue that's pulling off bone. It's that lining of bone. And then we have... So treatment depends on the cause, but one thing for sure that you want to do is toe taps. Manage your pain. Patellar dislocations is a fairly common issue. Anatomical versus forced. So what I want to put here is, so you can be born with a shallow groove, or a shallow patella that predisposes you to dislo. So that's kind of the anatomical. Or forced, it could be like a contact thing. Collateral damage, typically you're going to tear some ligaments. There's a ligament called your medial patellofemoral ligament is typically torn, and when you tear that, it just causes you to be more susceptible. Treatment, immobilize. This is like the easiest joint to relocate, honestly. And then we immobilize, relocate it, x-rays, make sure nothing else is wrong, and you're probably going to be out for a few months. Last one we're going to talk about is turf toe. So turf toe happens when you have a forced extension of your hallux. You got a couple sesamoid bones on the plantar aspect of your hallux and can injure that. Signs and symptoms. So definitely you got pain with extension whenever you go to push off. Tender to palpation on the dorsal head of the metatarsals, and also pain with weight bearing. There's a tape job you could do for it. And also, if it lingers, you could put a plate in the shoe to give your big toe some more stability. All right, so that's what we got for now. We'll recap this tomorrow. Have a good rest of your day.